This educational video is supported by an independent educational grant from AstraZeneca in recognition of the 10th anniversary celebration of World Thrombosis Day, held globally on October 13th.
Hi, my name is Greg Furman. I currently serve as Executive Vice Chair and Professor of Emergency Medicine at the University of Cincinnati College of Medicine. This educational video is in recognition of World Thrombosis Day, which is an international campaign that takes place on October 13th to shine a spotlight on the often overlooked and misunderstood condition of thrombosis, also known as blood clots. Dr. Paul Dobish and I both did some research on this condition, and Paul's going to tell us about it.
Thanks a lot, Dr. Furman. My name is Paul Dobish. I'm a pharmacist at the University of Nebraska Medical Center, professor here, and we're in Omaha, Nebraska at the College of Pharmacy. And our research really stemmed from the fact that over the last decade or so, there's been a relatively new class of drugs called the direct oral anticoagulants, commonly referred to as DOACs. And in their direct comparison to what used to be the standard of care, which would be a vitamin K antagonist, such as warfarin and others, that in these conditions such as atrial fibrillation, deep vein thrombosis, pulmonary embolism, where thrombosis or blood clots are common, the direct oral anticoagulants consistently showed better safety than the vitamin K antagonist, especially in the most severe types of bleeding, like bleeding into the brain, which we call intracranial hemorrhage, as well as fatal bleeding. But despite these advantages, these bleeding rates are still not zero. And with there literally being tens of millions of patients across the world on these agents, we're going to see these types of bleeds, even though they're less than the vitamin K antagonist. So, Dr. Furman, would you like to kind of describe for us in your emergency department kind of what patients should look for and when they should maybe seek care from you? Because these major bleeds, unfortunately, while less, will still occur.
You bet, Paul. So while they're uncommon, we do see them on occasion. So the two different classifications that we generally look for, GI bleeding and intracranial bleeding. Now, the GI bleeding is further classified as lower GI bleeding and upper GI bleeding. Upper GI bleeding is often characterized by pain in the upper abdomen just below the breastbone, also associated with maybe throwing up frank blood or passing black or tarry colored stools. Now, lower GI bleeding is usually associated with lower abdominal cramping and passing bright red colored stools. If you have either of those conditions, make sure you get to the emergency department rather quickly. Now, intracranial bleeding, it can be associated with trauma or not trauma, but is also associated with severe, sudden headache and then stroke-like symptoms such as weakness or numbness, maybe some slurred speech, maybe some severe dizziness. Again, if you have any of these conditions, make your way to the emergency department as quickly as possible. Now, Paul, tell us a little bit more about our research.
I will. So Dr. Furman and I, as well as some others, conducted some research because when these bleeds do occur, for a long time, institutions were using what we call the 4-factor PCC, or a 4-factor prothrombin complex concentrate, which was trying to just replace the factors that were being inhibited. We did this without really a lot of data, and we did this without even a known pharmacologic mechanism of action, but it's really what we had. Now, over the last several years, Andexxa, which is a kind of engineered antidote for these types of bleeds, has now also become available. And so people kind of, all right, well, is what we used to do, or is this new agent, what's better? And so we took a look at what hospitals were doing and what happens when patients get either one of these reversal strategies in the fact of these major bleeding episodes. And so we ended up with over 4,395 patients, over 354 hospitals across the United States and 42 different states. So very large database and a very diverse population. And what we found is that those patients who got the Andexxa, the designed antidote, was associated with a 50% lower in-hospital mortality rate than using the 4-factor prothrombin complex concentrate. And what was also very interesting is that we found is that magnitude, that 50% lower incidence of mortality, was there if the patient, whether they had an intracranial bleed or they had a gastrointestinal bleed, which is something that no one's been able to show before. And so, it's very, I think, people will need to now look at these data and this 50% lower mortality rate with the antidote. And I think this is good for patients, because where sometimes we wondered, like, well, what happens if I do have one of these bleeds, even though we're rare? We want to have an answer for that. And there is now an answer for that. So, you want to make sure that if these things happen, that you are going to an institution, talking to your clinician, like, all right, if this does happen to happen, am I going to be able to get the Andexanet, which is associated with the 50% lower mortality rate in the hospital compared to the other agents? Now, if this topic interests you, as well as looking at other topics, I would highly encourage you to go to the worldthrombosisday.org website, www.worldthrombosisday, all one word together, .org, to get more information, like I said, on this topic or others. Thank you very much for your time, and we wish you a good day.